Dr. Grom, I have a quick announcement that I need to make. Just one quick announcement. So last call for research. If anybody still wants to participate in research, they're open till 11:30. So is anybody here who would like to participate, or is everybody done?
So what I would like to do over the next 20 minutes is to start with a brief description of systemic juvenile idiopathic arthritis, the disease that I remember seeing as a fellow about 20, 25 years ago, and then discuss a little bit how this disease has changed over the last 10, 15 years. So as you know, systemic juvenile idiopathic arthritis represents approximately 10-15% of all the total SJIA population, and I would say the majority of patients with systemic juvenile idiopathic arthritis develop their first symptoms sometime between 1 and 5 years of age. And as you know, if it's diagnosed in a patient who is older than 16 years at onset, we usually refer to this disease as adult onset Still's disease. Now, at disease onset, the arthritis itself in these patients is completely overshadowed by the systemic features. In fact, in about 7-10% of the patients, the arthritis may not be present at all during the first few months of the disease. The systemic features include fevers, this very characteristic rash that most of you would recognize immediately. Many of these patients develop impressive enlargement of the lymph nodes. In this particular example, we are looking at the axillary lymph nodes that are clearly bulging. This protuberant abdomen reflects enlargement of the liver and spleen. And many of these kids also develop inflammation in the pericardium and the pleural lining of the lungs. And here we're looking at a massive pericardial effusion fluid around the heart in a patient with new onset systemic juvenile idiopathic arthritis. Now, although at the beginning all these features are very, very impressive, over time these systemic features tend to subside I would say, in the majority of the patients, at least in North America. And what happens to these kids long-term depends actually on the evolution of the joint disease, on the evolution of arthritis. And unfortunately, in about 50-60% of the patients, we see this sort of very aggressive, very persistent, what we call polyarticular disease that affects many joints and leads to destruction of those joints. In fact, in this group of patients, we see early destructive changes as early as during the first couple of years of the disease. Unfortunately, hips are involved in approximately half of those patients, and if that happens, approximately 1/3 of those kids will need a total hip replacement surgery before their 16th birthday. Another characteristic feature of systemic juvenile idiopathic arthritis is what we call ankylosis. Ankylosis is a fusion of bones. And in this example, we are looking at the fusion of vertebral bodies in a patient with systemic juvenile idiopathic arthritis. And certainly, this kind of fusion will limit the ability to move neck. And this particular abnormality, for example, will be very, very critical for driving when you need to move your neck left and right. So that's a sort of very, very important feature. We also see similar bone fusion often in the wrists and in the feet, again, limiting the ability to function. In this example, we are looking at the destructive changes in the knees. So I would like you to look at this particular space between the bones. It's filled with cartilage. And the size of this particular space reflects the thickness of the cartilage. And as you can see, on this side of the joint, the cartilage is completely lost. We see erosions in the bones. And certainly the ability to move a joint like this is very, very limited. And that certainly eventually leads to major functional disabilities. And as I told you earlier, in many of these patients, we would see this kind of changes during the first couple of years of the disease. And I'm just showing you results of a couple of epidemiologic studies performed in the early 90s and then in the years 2002 and 2003. This particular study was performed in the United States, this one in Canada, this one in Europe. And the bottom line is that during the first couple of years of the disease, somewhere between 30 and 45% of the patients will have these massive destructive changes in the joints, limiting the quality of life of these patients. Another way to look at the systemic juvenile idiopathic arthritis is sort of kind of view the long-term course of the disease. In some patients, we see what we call a monocyclic course. These patients develop typical features of systemic juvenile idiopathic arthritis. They may persist for a couple of years, but eventually they go away. Whether we treat those patients or not, the damage to the joints still can occur, but the disease eventually goes into remission and does not progress anymore. So that's a monocyclic course of the disease. In some patients, this disease actually may come back later again. It may happen 3, 4, 5 years later, and we would describe this course of the disease as polycyclic. And then certainly more than half of the patients, at least 50, 60% of the patients, would have this persistent course of the disease when the disease progresses unless we stop it with medications. The proportion of patients that have this relatively benign monocyclic course depends on the geographic area. This particular study was performed in Canada. It's probably in Canada, it's about 42%. We think that in Cincinnati, the number is similar. If you look at the European experience, the proportion of patients with this monocyclic course seems to be much smaller. Now, briefly, I would like to discuss some of the complications of systemic juvenile idiopathic arthritis. Certainly, in addition to those destructive changes in the joints, we are concerned about growth abnormalities. These two girls, in fact, are twins. One is healthy, the other one had been affected with systemic juvenile idiopathic arthritis, and you see the difference. Another major complication that we worry about is macrophage activation syndrome. In fact, this particular girl, it's the patient that we lost when I was a fellow because of macrophage activation syndrome. It's a clinical syndrome that is caused by excessive activation and multiplication of predominantly two types of immune cells, T cells and macrophages. And the excessive activation of these cells leads to a massive inflammation that actually often is life-threatening. Now, normal macrophages, it's a type of white blood cells that typically engulfs and destroys microbes and other foreign substances, and this process is called phagocytosis, and that's how it looks. This large cell in the center is actually a macrophage, and you see this macrophage phagocytosing microbes and eventually destroying them. Unfortunately, in many patients with systemic juvenile idiopathic arthritis, these cells get overly activated, and unfortunately, they start phagocytosing and destroying normal blood cells. And that's a typical biopsy from a patient with macrophage activation syndrome. These large cells in the center of each of the figures are in fact macrophages, and you see they're kind of sticky. Other normal blood elements adhere to their surface, and eventually these cells get phagocytosed the same way as bacteria would be phagocytosed. In this example, we are looking at a couple of neutrophils sitting inside a macrophage, and eventually these cells get completely destroyed. In this example, we are looking actually at the remnants of those normal cells, and this may lead to life-threatening drop in cell counts, including drop in neutrophils and hemoglobin and platelets. And unfortunately, the mortality rate in this particular complication still remains rather high. The established treatment of MAS includes high-dose corticosteroids, cyclosporin A, anakinra certainly in some patients, and in most difficult patients, we occasionally would use etoposide. It's a very, very toxic medication that has the ability to kill pretty much all the immune cells, and that potentially can lead to a life-threatening bone marrow suppression, so we can block the ability of the bone marrow to produce normal blood cells. So it's a toxic medication, and we would use it only in the extreme cases. And there are a couple of treatments that are currently under investigation. Certainly, we are about to start a clinical trial of anti-interferon gamma antibodies here in Cincinnati. We believe that blocking IL-18 may help prevent episodes of macrophage activation syndrome. And also there is a question whether, in fact, JAK-STAT inhibitors might be helpful in macrophage activation syndrome as well. Another complication that I would like to mention is amyloidosis. When we develop inflammation in the body, whether in systemic juvenile idiopathic arthritis or in the case where we are trying to fight infection, we produce many inflammatory proteins. One of them is called serum amyloid A. I think in microbial infections, actually, it helps fight microbes. But unfortunately, when it's produced continuously at a very, very high level, it can kind of crystallize or precipitate in many tissues in the body. And that precipitation, accumulation of that particular protein into tissues can completely disrupt the function of those organs. And in this example, we are looking at the accumulation of those precipitations in kidneys, and that potentially is life-threatening as well. So interestingly, this particular complication is exceedingly rare in North America. However, it was actually very common in Europe, particularly in Northern Europe. In some countries, the prevalence of this phenomenon among the patients with systemic juvenile idiopathic arthritis was reaching 20–30%. It was actually very, very prevalent in the years in the 70s and the 80s. And then for some reason, it disappeared, and we don't understand what exactly happened. Certainly, we did not introduce particularly new treatments at that time. So we suspect that there was something in the environment that induced that complication, and that factor, the environmental factor, suddenly disappeared, and we stopped seeing this complication. Now, Grant earlier showed you this slide. That's the sort of historic perspective on the treatment of juvenile idiopathic arthritis, and I would like to make a couple of points here. What made a huge difference for patients with juvenile idiopathic arthritis in general is the introduction of methotrexate in 1991, and then the introduction of anti-TNF inhibiting agents and abatacept somewhere between the years 2000 and 2010. And the widespread use of those biologics dramatically improved the outcome of patients with non-systemic juvenile idiopathic arthritis. However, that evolution, natural evolution of the disease that I just described to you earlier, was not affected by these treatments. And it was the time when we started learning, actually, that systemic JIA was different from other subtypes. We realized that it was more about the spontaneous activation of the innate immunity rather than adaptive immunity. And we realized that many of those patients would have increased activity of two cytokines, IL-1 and IL-6. And just to remind you, cytokines are sort of, you can view them as chemical signals that immune cells used to communicate with each other. They send those chemical signals to sort of activate each other, and IL-1 and IL-6 are produced predominantly by the innate immune cells. So when we realized that, we sort of started working on new treatments to approach this disease. And at that time, two pharmaceutical companies, Novartis and Roche, came up with two new drugs. One was tocilizumab. It was Roche that produced it, and it was blocking, neutralizing the activity of IL-6, and Novartis came up with a monoclonal antibody neutralizing IL-1 beta. The two very important clinical trials were completed in 2012, and these two very, very important papers were published in the New England Journal of Medicine in December 2012. And I just would like to sort of mention a few numbers that were generated in this particular clinical trial. So on the left side of this table, we are looking at the clinical trial of tocilizumab. That's a drug, or Actemra, that's a drug that blocks IL-6. And we are looking at the outcome of systemic juvenile idiopathic arthritis in the patients enrolled in the trial at 1 year. 90% ACR 90 response rate. That's a 90% improvement in terms of clinical features of systemic juvenile idiopathic arthritis in almost 60% of the patients. Completely inactive disease in 1/3 of the patients. Absence of active arthritis in 50% of the patients, and about 52% of the patients, of those patients who were on steroids at the beginning of the clinical trial, were able actually to completely stop steroids. Similar numbers were obtained in the clinical trial of canakinumab. So because of these two publications, both drugs were approved by the FDA, and I would say from the year 2013, we started using these two medications in addition to anakinra on a regular basis. And that's certainly something that did change the outcome of the disease in a very dramatic way. I would say in approximately 70–80% of the patients. So our impression overall that blocking either IL-1 or IL-6 should produce a very good control of the underlying disease in about 70–80% of the patients. And we suspect that about 15–20% of the patients may have other pathways, other critical cytokines involved, and we are trying to identify what those cytokines might be. So because of this, I don't remember, in fact, when was the last time I saw this kind of changes in the joints in patients with systemic juvenile idiopathic arthritis. So this terrible joint disease seemed to be disappearing. These kind of growth abnormalities we still see occasionally, but it's becoming exceedingly rare. However, some other complications of systemic juvenile idiopathic arthritis still occur, and that includes macrophage activation syndrome. When we realized how good those medications were for most of the patients with systemic juvenile idiopathic arthritis, how well they control the underlying disease, our expectations were that with a better control of the underlying disease, we would not see macrophage activation syndrome. Unfortunately, that was not the case. And if you look again at the results of those clinical trials that I mentioned earlier, we realize that although the risk for macrophage activation syndrome in these patients is not increased, but we certainly do not see protection. We may see a full-blown, life-threatening macrophage activation syndrome even in a patient whose disease is very well controlled, whose systemic JIA is very, very well controlled with the medications. Another complications that we started seeing more frequently is the lung disease that you will hear about in a moment. This particular paper was published by Yuki Kimura in 2013. In that report, she described 25 patients with life-threatening lung complications. 16 patients had pulmonary artery hypertension, 5 patients had alveolar proteinosis, and 7 patients had interstitial lung disease. So interestingly, if you look at those 25 patients, most of them were diagnosed after the year 2000. And certainly that increase in the number of patients did coincide with the introduction of the biologics. And that's the experience in Cincinnati. So here we're looking at a total number of unique patients with a lung disease and newly diagnosed per year. And you see sort of clearly there is a sort of increase in the number of those patients starting in the year 2012. So overall, I would say on a continuous basis in Cincinnati, we are following somewhere around 75 patients with systemic juvenile idiopathic arthritis. And over the last few years, we have diagnosed 5 of them with a lung disease, suggesting that the prevalence of this particular phenomenon could be somewhere between 6% and 7%. And I would like to stress the point that although we do worry about the possibility, about the possible connection between this complication and the lung disease, we certainly have seen this disease occurring in patients who have never seen biologics. Just a couple of weeks ago, I spent a week in China, seeing patients with systemic juvenile idiopathic arthritis. Canakinumab and anakinra do not exist there. Actemra does exist, but it's very expensive, and the patients there need to pay for this medication out of pocket, so only few of them actually get this medication. And still, quite a few patients there that I saw had exactly this lung disease. So we still need to understand better what's the reason for this disease. Certainly, we need to consider the possibility of biologics causing this trouble, but certainly other possibilities should be considered as well. So the one thing that we have noticed in patients here who develop this disease, first of all, many of them, if not all of them, in fact, have either sort of low-grade persistent MAS or recurrent episodes of macrophage activation syndrome. And the other interesting feature is that I mentioned to you earlier that typically in patients with systemic JIA, those systemic features tend to go away over time. And I have a feeling that in this group of patients, the systemic features tend to persist longer, suggesting that it may be biologically a slightly different group of patients. So now the next step is to understand why is it happening, so what this disease is exactly, and why is it happening. And I would like to thank almost all of you, in fact, for giving the blood samples during this meeting, because one of the in fact, a few of the projects that these samples will be used for are focusing on understanding of this lung disease. And I think what you did is going to help all of us to answer this question, why is it happening? And now I would like to introduce Chris Chow. Chris Chow is a professor here in Cincinnati at Children's Hospital in the Division of Pulmonary Biology, and he directs the Clinic of Rare Pulmonary Diseases, and he is helping us quite a bit on the clinical side, but he also helped us to understand the biology of this disease and develop possibly new treatments. Thank you for your attention.
Questions, and we'll just run a few minutes. Mindy.
Have you guys done any research on which biologic there is more tied to within MAS and the lung disease? Or is it pretty consistent across the board?
Right, so the question is, do we, if we think about the biologics that we are using for the treatment of systemic juvenile idiopathic arthritis, do we believe that the biologics are different? I certainly don't think they are that different. We certainly see MAS at roughly the same rate in patients treated with canakinumab, anakinra, or tocilizumab, or Actemra. So in general, if you sort of think about, when I go back to those years when I was here before the biologics, we would see approximately, the rate of MAS was somewhere between 4 and 6 events per 100 patients years. In other words, if we have 100 patients and we follow those patients for 1 year, somewhere between 4 or 6 of them will develop full-blown macrophage activation syndrome during that year. When we looked at the data from the clinical trials of canakinumab and tocilizumab, the numbers were actually very, very similar. So perhaps it was slightly higher in the canakinumab clinical trial, but again, it was certainly not that different. So that's the reason I'm saying that we believe that the effect is neutral. For the lung disease, the only thing I can tell you, certainly we see patients developing the lung disease on both all the 3 biologics. What complicates things a little bit, because I think that these patients who develop lung disease are difficult patients. And most of them require switching and changing biologics many times. So by the time they develop the lung disease, actually most of them had been on pretty much all of them. So that certainly complicates epidemiologic studies, but we do try to sort of design a proper epidemiologic study that would address exactly this question.
Any quick questions?